Welcome everybody to our joint webinar today that we are giving with, and I'm very happy about this, that we as OECD have teamed up with the European University Hospital Alliance. The European University Hospital Alliance is going to meet tomorrow here in Berlin to think about, rethinking European healthcare systems, and with a focus on the sustainability of the European healthcare workforce. And we discovered when during an informal exchange that fits very well an OECD report which just came out, which is about lessons learned from the past, from the pandemic, and what needs to be done to build resilient healthcare system. So today, my colleague Phil Haywood from the OECD Healthcare or Health Unit Division is going to present this report. And then I'm very happy to be able to discuss this with very distinguished experts, doctors, directors from different European university hospitals. There's Professor Hajo Krömer, who is the Director of Charité here in Berlin. Gabriela Kornek is from the University Hospital in Vienna, and Catherine Pogam represents the APHB, so a big university hospital group in Paris. And we are also joined by Reinhard Busse, who is a distinguished health economist here in Berlin and has contributed to the expert group who has looked into the hospital reform that is being programmed here in Germany. And Matthias Mieves is a member of parliament and an expert on health, again, a health policy maker. So that makes for a very diverse and good group. And I'm really looking forward to the debate. But without further ado, Phil, I'm going to give you the floor and you can put up your slides. And we are very interested in learning what the lessons are that you think the world has learned and what we can make of that.
Perfect. So thank you, Charité and the European University Hospital Alliance for the opportunity to present the OECD's recently published report on health system resilience. This report uses the lessons of COVID-19 and applies them to make recommendations for the future. We are really grateful for the involvement of many countries and country experts, including Germany, although this report reflects the recommendations of the authors and not any member country. This report makes recommendations in specific areas, drawing on the expertise across the entire OECD. However, today, in the interest of brevity, I'd like to focus on the identified 6 key policy areas. 3 are within the health system: improving health prior to a shock, ensuring a sufficient and skilled workforce, and better use of data. And then 3 move beyond the health system: furthering international collaboration, especially around investment, improved supply chain resilience, and ensuring governance and trust. How are these 6 areas identified? What benefits are expected? And why will they help making health systems resilient? I'm going to now step through why this report exists and what it aims to achieve. There are many definitions of resilience, but they all contain the idea of absorbing and bouncing back from adversity. There is concern that even strongly performing health systems or systems based on strong components may not have correspondingly strong resilience. This is based on experiences both within and beyond health. Within the health system, the 2014 Ebola outbreak had larger impacts in some systems that were considered strong because they weren't well integrated internally or with other sectors. And beyond the health system, based on experiences from the financial industry, where individually strong banks did not result in an overall strong system. So the focus needs to be on the system and system behaviour under adversity. The policy relevance is to ensure that systems not only perform well between crises, but during them. Some of the main areas of difference with health systems performance is that we identify connections beyond the health system. We consider time and the dynamic responses of the system, and we recognise the potential for feedback loops and the inevitability of shocks occurring. All these differences features in the identifications of the key policy areas. Societies need to adapt their health systems to respond to risks beyond pandemics. Challenges that are emerging as we speak include antimicrobial resistance and climate change, each of which can be compounded by a polycrisis, as we've seen the pandemic was compounded by a polycrisis. And this is how we're conceptualizing the dynamic component of resilience. Before a shock occurs, we're in the prepare stage on the left. We make plans. Then when a sufficiently large shock occurs, the performance of the health system suffers as it is disrupted and absorbs the situation. Then over time, the health system recovers its lost functions, learns from the experience, and adapts to be both better performing and more resilient in the future. The central issue is that the health system, is trying to do different things during each of these stages. It's trying to do different activities. It needs different information and potentially different organizational structures to deal with the issues in each stage. Another incredibly important point is that decisions made in one stage can affect others. And thirdly, we assume that you can't avoid all problems. Eventually, the system will be subject to a disruption. The policy dilemma is to make the red as small as possible and the green as large as possible, while preserving a high degree of performance. Previous work in resilience has suggested that the concentration of research is in the first two stages and not the last two, but all are important. So let's use that framework to examine the policy recommendations. The first is the need to promote healthier populations. A relatively low health system expenditure on cost-effective health promotion and population health is a focus in the report, but it's much larger than that. It involves universal health coverage, primary care, integrated care, and the socioeconomic determinants of health. As we all saw in the pandemic, and the slide demonstrates, mortality and other outcomes were worse for those with vulnerabilities. Here a socioeconomic gradient exists and the mortality doubles for those in the most deprived areas versus the least. I want to emphasise that while increasing prevention in primary care is an important technical and allocative efficiency argument for a high-performing health system, the reason that we are advocating it as a resilience aiding policy is that disruption of services and disruption that occurs during crisis is particularly problematic for those with severe multimorbidity. Societies with less prevention and more treatable morbidity will find absorbing harder and recovery will be slower because demand for healthcare will increase during these times of crisis. And the consequences of delaying and avoiding care will also increase. And a potential feedback loop begins to emerge where increased effort is diverted to treatment, reducing prevention, which worsens population health, which increases the amount of effort on treatment. Therefore, a shock means greater disruption and slower recovery. The second recommendation is around workforce. This slide demonstrates the very simple association between a larger workforce and reduced excess mortality in the first 2 years of the pandemic at a country level. This simple association, increased workforce is correlated with decreased excess mortality, continues to hold in more complex modelling, both that conducted in the report and some, but not all, academic pieces. The workforce demonstrates the importance of considering all stages of the disruption cycle. It's simply not enough to ensure that workers exist to absorb the shock, especially if increased effort is used to absorb the shock. Increased effort as a solution makes recovery for the system harder the longer disruption continues. And we can see that in some countries now. That workforce is a key issue for resilience is highlighted by considering that most other problems were progressively solved during the critical care surge, but the issue of sufficient and skilled workforce remained. Infectious diseases shocks are notorious for putting the workforce at risk and sometimes mortal peril. And protection, physical, mental, social, and financial is required. However, most large shocks will have an impact on workforce availability. We estimate that over 3 million extra health and social care workers across the OECD will be needed to improve resilience. Continuing the theme of workforce is the requirement for staff to fulfill different roles in response to different challenges over the disruption cycle. Because there is a wide range of different threats and different recoveries, agility of the workforce is paramount. We saw this during the stage of absorbing the pandemic with widespread role changes, both in what services were provided, who provided them, and where they were provided. This slide shows the wide variety of additional roles taken on by non-physician healthcare workers during the pandemic, not to mention the enormous implementation of telehealth across OECD countries. These changes needed to be supported by financial, organisational and governance structures that reinforce them. And then as we move to the recover stage, a different set of skills are required. Being unable to have sufficient staff makes this process more laborious. Not having agility in the workforce makes it more difficult. Not being able to absorb quickly and not having sufficient staff results in greater disruption. This slide shows a reduction across OECD countries of hip replacements in 2020 as a percentage of activity compared to 2019. Some countries face a very large burden of deferred care that may need to be caught up on, whereas others do not. And of course, there is a concern of another feedback loop within the health workforce, that increasing harm reduces the health workforce, resulting in a greater burden on those who remain, increasing the harm, which reduces the workforce. And while we have highlighted workforce as key to responding to challenges, we highlight data and information as vital to understanding what to respond to and to support organisational changes, identify unintended consequences and promote decision-making based on evidence. Again, a key issue is not simply that we need greater data more readily, but we also need the ability to quickly develop and integrate new data sources as required. For example, during COVID cases, testing, and even wastewater SARS-CoV-2 results all needed to be integrated into information systems. At the beginning of the pandemic, few countries had real-time data. This slide shows the policies implemented in OECD countries to manage the critical care surge. And what is striking is the number of policies that rely on high-quality data for decision-making and organisational restructuring. Data underlies the use of relatively scarce critical care resources effectively. And as we progress through the pandemic, we need different sorts of data. Data on vaccination, data on delayed and deferred care, data on mental health, data on long COVID, data on well-being, and data on educational impacts to make decisions. High quality data available to those who need it allows us to identify and respond to weaknesses quickly. Beyond that, a mature data system helps to absorb and recover from disruption. Data that follows the patient mitigates the harms of transitions that occur with disruptions. Telehealth is easier to implement, and care between crises can be made more integrated and effective. Our fourth recommendation underlies the interconnections between countries and the benefits of acting cooperatively and the dangers of not doing so. Some actions have a lower cost and a greater benefit if taken collectively. Infectious diseases surveillance for one, and reducing the spread of infectious diseases benefits all. Another example is investment. Many of the products and technologies that we need during a crisis have a weak business case during non-crisis times. We don't need them at that time. COVID vaccinations are an example of that. We have seen that it's possible to create these in a short period of time with enormous investments. But as the slide shows, the results may be inequitable. We need to make it possible to research, develop, and distribute essential technologies for absorbing and recovering from a crisis in a fast and efficient way. But the benefits of international cooperation are much larger than simply investment. Sharing of staff, resources, and even the movement of patients to lower the burden on individual areas occurred during the pandemic. The ability to combine information and share it rapidly around systems improves the speed of responses and the evidence base on which decisions are made. For example, the use and sharing of COVID-19 related data facilitated safe global travel through the use of international vaccination certificates. International trials were launched during the pandemic. But a key issue that emerged, and will emerge again, is a lack of certainty around the right policy options. For example, we still don't know precisely which containment and mitigation measures worked and what suite of measures will be best used in the unfortunate event of a future pandemic. The greater ability to link data and translate learning from one country to another, the faster we will be able to manage the crisis better. And then lastly, planning on an international or regional level allows a degree of efficiency in planning. For example, the stockpiling of essential medicines and medical devices, reducing the cost for individual countries. but it needs to be accompanied by credible mechanisms for when widespread shortages take place, and we should assume they're going to take place. Without these credible mechanisms, versions of a feedback loop of hoarding could occur, where the fear of a shortage creates the shortage as each country attempts to gain its own store of supplies. Limited versions of this occurred during the pandemic, with, for example, export restrictions on key items. Which brings us to the fifth recommendation: supply chain resilience. Shortages in medicines and medical devices are not new, but the acute shortages at the beginning of the pandemic were devastating. This slide shows the characterization by OECD countries of the shortages in devices and medicines used in the absorb stage of the COVID-19 disruption. As we all remember, personal protective equipment, ventilators, and testing equipment were in short supply across almost all OECD countries. Feedback loops occurred where increasing infections and border closures interrupted supply chains, reducing availability even further and making the risk of infection even greater. Most countries responded by diversifying suppliers and engaging in local and near local production, but there was still a gap in time that had to be filled with limited resources. Over time, production increased and the demand fell, but the issue is how to reduce the impact and the time of very acute shortages. We are suggesting three main areas for this. First, greater information to anticipate, diagnose, and implement effective policy choices. Second, procurement strategies guided by that information that enhance the resilience of supply chains, for example, diversification. And third, considering stockpiling strategies holistically, so the aim is achieved. Again, it's important to consider how each of these stockpiling and other strategies are going to work together during the absorb stage and the recover stage. Trust and governance beyond the health system is essential, as we have seen during the COVID-19 pandemic, and we will see again. Sufficiently large shocks require a whole of society approach under conditions of extreme uncertainty. This slide shows a simple association between COVID-19 vaccinations and excess mortality in 2021. Increased success in vaccinating the population is associated with decreased excess mortalities. Without governance mechanisms beyond health, effective policies cannot be introduced. And without trust, policies may not be adhered to. As we saw during the pandemics, policies may change as evidence is accumulated. This should actually be expected and planned for. Misinformation and disinformation have increased in many countries, and proactively dealing with these issues is important. This is just a reformulation of the 6 policy areas into actions for a resilient health system. What we're trying to do with these recommendations is reduce demand in times of crisis, shorten the times of extreme disruption, and facilitate agility, cooperation, and evidence-based decision-making, all the time recognizing that there's going to be uncertainty. But is a resilient health system the most efficient health system? There is a debate around this point, with some resilience experts arguing that highly efficient systems are not resilient, that they are not able to take shocks without destruction. And a degree of efficiency should be sacrificed to ensure that the systems can withstand shocks and not fail. We recognize that there are going to be trade-offs. Our estimates of the cost of the 3 policy areas within the health system are that an extra 1.4% of GDP may be needed to be spent in health relative to the 2019 expenditure, the pre-pandemic expenditure. Most OECD health systems have already increased their investment in these areas: prevention, workforce, and the digital foundations of health. On to the question of whether there will be a trade-off between performance and resilience. Hopefully, some of the suggested policies will improve both. Better data and greater prevention will improve performance as well as resilience. For others, there may well be a trade-off, and this will have to be reviewed and adapted as new evidence and new research emerges. This is an ongoing conversation, and we need better measures and more testing of resilience to undertake this over time. However, without considering resilience, health systems and societies will be vulnerable, and large, costly, less effective interventions and more harm will be the result when we face the next crisis. There's more detailed information in this report on the topics shown here and is available on the OECD website. Thank you very much for your time and interest, and I look forward to the discussion.
Yeah, thank you very much, Phil, for this introduction. And I think there are many items that you brought forward that I think I would like to put to Hajo Krömer, Professor Hajo Krömer, who's the host of tomorrow's European University Hospital Alliance workshop. And what I would like to know, because we heard, well, that international cooperation is important in order to handle a pandemic. We also heard about a need for better data. And we had a discussion before about the European University Hospital Alliance. So I think you existed before the pandemic, but you told me that you worked quite well during the pandemic, informing each other, perhaps learning from each other. And I would like to know, how did that work? And did you share data, for example? And how does this inspire your joint work going forward?
Thank you, Nicola, for that question. Just a brief background on this European University Hospital Association. We are 9 large academic medical centers throughout Europe, which have kind of connected a couple of years ago. And the idea is to improve everything in academic medicine, from healthcare to academia, to workforce questions and things like that. And so let me make a general comment on European interaction in the crisis, which I think really needs improvement, because during COVID-19, Europe, from my point of view, did not perform really well. We had restrictions at borders. We had part in disrupting connections. I remember very well when the German government declined to export ventilators to Italy and things like that, which should not happen. In the alliance, we worked closely together in terms of information. So we had among the CEOs a regular exchange about the actual situation in COVID-19, and that helped us a lot, because for reasons unknown, for example, Paris was always 4 to 5 weeks ahead in the pandemia development compared to Germany. So when I would call my colleague in Paris, I would know that within 5 weeks we would be at the same situation where he is now in terms of ICU and other things. So there was an information. However, in retrospect, we have to say that it was not really structured. We did not exchange data in a way we could. And these are things we are currently discussing to improve them in case the next crisis comes. So overall, it was a positive experience to get an interaction with in the international field. And last remark, inside Germany, we were able to establish a network of academic medical centers, which is headed by Charité. So all academic centers, medical centers in Germany, really formed a close co-work during this crisis. And we are thinking about moving this type of net also to Europe. So some positive examples. On the other hand, I'm pretty sure, and like to hear what the colleagues say, the international interaction, at least in Europe, should be improved during the next crisis. And I guess from OECD, you should have a very careful look at that.
Yeah, thank you very much for these insights. And I think that's a good, that prompts me to perhaps ask the other representatives of the European University Hospital Alliance, Professor Pogam, Catherine Pogam from Paris. So it sounds a bit like you were in the unlucky position that you had to inform everyone else, or I don't know everyone else, but Germany at least, what would come. But yeah, perhaps you can give us your reflections on the cooperation, but also whether what you just heard from Phil from the OECD resonates with the lessons that you have drawn in France from this experience.
So I would say that I don't know if we were in an unlucky situation, because at the beginning, and at least during the second and the third waves, there were the England was before us, and especially for the Omicron wave. So it has changed during the time, and at the beginning it was our Italian colleagues that gave us some information. So the point that you made, thinking about the way we can just trying to put all this information that were at the beginning very informal, trying to go through network, open network, sharing data. This has been a little bit said during Philippe talk. And based on what we all in our own country at least have, our networks that are able to share some additional and put some additional data together. This made this, if we want this to be efficient, we need to address some topics about interoperability of our data, which is, I think, at this time, right now, the main issue we have to deal with. In the EU, in the Alliance, we are trying to work on, not on COVID, but on benchmark about our results about breast cancer, for example. And everybody, we have our own data about this. And at this point, we are trying to exchange about our data. But the point is, we need to go through this this way of making our data on the same format to be able to exchange. So this is going to be maybe my first point. My second point would be more general about, I don't know if it's a difference between resilience and performance, but I think the point is that during crisis, there was money was not the point. And there was one question we talked about before, but money was not the point, and we have the freedom to do everything as I am an intensivist, so we have the freedom to make every command we need, to order for what we need, despite the shortage for sure, but money was not the point. When we are considering how we recover, and I am not sure that we are right now I think we are still in the recovery phase, and we are far from going to adaptation and far from being more performant or more resilient that we used to be 3 years ago. But the point is, if we are considering that maybe we need to put some more money, maybe, or at least considering to have the opportunity to think about how resilience can be built. This is not only the point for healthcare system. This is the point for our society. Our society needs to be aware of what they want for the future. For the future of healthcare system, do we want to be very able to care and to cure for all the chronic disease? So do we have to put a lot of money on prevention? Do we have to be able to, for every crisis, be able to take care of the crisis, but also be able to continue and to perform our daily care and all the care we need? And so this is a choice for society, I think. And my third point maybe would be about, I am not sure we have totally learned all the lessons for the crisis. And I would just maybe share one example. What is the cost of a lockdown, for example, considering the first results we have on mental health of at least for our young people in our society. So I think there is a lot of things that need to be learned from what we have been through during these last 3 years.
Thank you very much, Catherine. And yeah, I think there's one aspect you brought forward, which is this decision for society. What kind of healthcare system do we need? And Professor Kornig, Gabriela Kornig, I would like to ask you. You're also heading a director of an important university hospital in Vienna. And Phil made this point that there's perhaps some trade-off. So if you want a resilient healthcare system that still performs in a crisis, you need to put more money than if you construct the most efficient healthcare system that you can think of. And specifically, I mean, in this crisis, what we saw, of course, is that the workforce suffered enormously, and many withdrew from the system. And this is also, I think, why you chose the theme of your workshop, your conference tomorrow. And how do you see this particular aspect, and how is it seen in Austria now? Do you need some slack in the system in order for the workforce to be able to cope, or is the workforce shortage such that it's not even possible, that we have to put everything into prevention? What are your thoughts on this?
I think the shortage is not only based on the pandemic. It begins earlier, much earlier. And I think that the public now perceived that health professions are key personnel, and the health cares knows, or they used the pandemic to make the situation public. Yeah, it's a personal feeling, and we all know that the stress during the pandemic was very, very high. They had to work every day hard, and all the situation was hard. But I think the main one of the main topics in our system is that they had to, well, they want to have another working times, completely contrary to that what they have to offer during the pandemic. And one issue which is discussed every day is that the lack of duty roster reliability. So I mean, the medical staff has to plan the holidays, and we have to guarantee that. So this is one of the most discussed topic in our hospital. And this is not since the pandemic, it starts earlier. And this is not only among the nurses, but the whole population of our healthcare workers. Yeah, I think this is where we have to work a lot, and we have to plan it.
So working conditions are really important. Yeah. Matthias Mieves. So the German Bundestag, well, I'm not quite sure at which stage we are, but in Germany, a hospital reform has been put forward. And I don't want to go into the details now, but more as a health policy maker in Parliament now. Is a reform of hospitals, is that the main issue you think you need to work on? Is that really pressing? Well, probably it is, but what are other elements? Do you feel all the lessons have been learned, or would you concur with Catherine to say, well, there are many things we still don't understand, we have to analyze? What is it in German Parliament where you think these are things we need to work on to really learn the lessons and build a better and more resilient healthcare system?
Well, thanks for these questions, Nicola. These are very good and a strong question. So first of all, I believe the lessons are learned, but we haven't done our homework yet. There is still a lot to do for us as a parliament in Germany, but for the complete health system as well. And you mentioned the hospital reform. Absolutely, that's an important piece of making our health system in Germany future proven and future ready, but it's not the only thing. I would like to focus on another aspect where we need a big change in Germany, and it's the usage of data. We heard from your analysis that we need a sound fundament for decisions in a crisis in the health system. And this sound fundament based on data, on real-time data, does not really exist in Germany. That has many reasons. One reason is that we haven't achieved a system where we would have a digital medical record in Germany. So we need a digital health record for everyone in Germany. This is one big project we have within our government agenda of the new progressive government in Germany. That's something we need to bring into the legislative process this year so that we can achieve some success in the next few years. And our goal should be to implement a digital health record for everyone in Germany that can be used in hospitals, in our various parts of the health system. That's something that countries like Sweden, Denmark have had for decades, and we still haven't achieved that in Germany. That's one big project we have for this government, and it's on the legislative agenda for this year. A second topic which we will address is in general the usage of data in the health system for science, but for therapies as well. And we will have a second legislative package we will discuss in the next few months to bring this forward that makes it easier for scientific projects to use data and basically to create a legislative framework that makes it possible to work in a scientific way with health data in Germany, but makes it possible to cooperate on a European level as well. Because at the moment, the legislative framework, even within Germany, is too fragmented because we have differences between the 16 states in Germany. We have fragmented competency when it comes to data protection. And that's the homework we have. We need to clean this up and bring clear regulation so companies, hospitals, universities, institutions can better work with health data in Germany. And the third point I would like to mention is interoperability. It's a very technical expression, but in the end, it means that we need the various data islands, the various data silos we have at the moment. We need to connect them to each other because there is a lot of data, even in Germany, even in a digital format, but it's locked up within singular hospitals or institutions. We need to bring it together. And we, from a government, from a legislative perspective, we need to enforce that we bring these data, pieces of data to standards, we make it interoperable. That will need money, but it will need a stronger legislative framework as well. Otherwise, we will not progress. So in the end, data saves lives, and we need for that some central projects like the digital medical health record. We need a stronger legislation around health data in general, and we need to clear up the competencies around data protection. That's the three pieces we have on our agenda for this year.
Thank you very much for giving us this input. And Reinhard Busse, you are so you contributed to the hospital reform we just mentioned. So I, together with Hajo Krömer in an experts committee, what I would like to know from you is, so we talked about the trade-off, efficiency, resilience. Is this reform meant to make the system mainly more efficient or more resilient or both? And how does that work? And perhaps then also going a bit beyond the hospital system, because you have the broader view as well, I think. So I think Germany, all three countries represented here, Paris, France, Germany, and Austria, and Phil, you will correct me if I say something wrong, are something that we call at the OECD rather hospital centered. So where, you know, you could make better connections with outpatient care, perhaps even do some things and ambulatory care that now you do in hospitals. So for the broader, so if this hospital reform goes through, what needs to be done beyond that, in your view, in order to make for an efficient, resilient, sustainable healthcare system here in Germany?
Yes, thank you for these questions. I think it's important to realize this trade-off. And in a sense, this is also new, because I remember at the beginning of the pandemic, people were also, OECD was putting up figures, how many ICU beds, how many hospital beds countries would have. And the assumption, or at least it looked like, these pictures should say the more hospital beds, more ICU beds you have, the better you are prepared. And it turned out that this was not true. I mean, it's not that simply the more the better. So the less you are efficient, the more you are resilient is also not true. So the opposite is not true. I think we have learned that, but it's also important to realize that the inefficiency or the oversupply of beds also means a country had a very different starting point. So, for example, when you look at the reduction in the hip replacement numbers, which Philip showed, then some countries would say, yeah, this is deferred need. People did not get their treatment because the hospital sector broke down due to shortages and so on. While in other countries like Germany, we would argue, first of all, you saw that for hip replacement, there was also only a small drop, but we would say, okay, we experienced a drop in case numbers, but this is good, because even in a big health crisis, the health system reduced the necessity to the really more appropriate cases. So inappropriate cases were not treated. And so a reduction in case numbers can be interpreted very differently. And in our system, a bit like Austria and other countries also, we are coming from one end. And I think it's important to realize that this lesson from the pandemic is not true exactly the same for the other countries. So we saw that we were inefficient, which was not good, because the staff was also very much distributed across the country, and it was, I mean, there was great cooperation, but the cooperation, who was exactly doing what, needed to be done, you know, ex novo during the crisis. And so in the hospital reform, we are now saying we need to be much more transparent, be clear which hospital is working at which level of care, what is exactly the requirements for each level, so that you know this is a hospital where you have a good intensive care unit, for example, while there is another hospital where you don't have that. So transparency, making it clear who can do what, and also saying that hospitals are only doing what they can really do, and that not all hospitals assume they can do everything. And that means for us at least a concentration of services, also realizing the importance of the workforce, and that the workforce has increased across the OECD countries since 2000 by 50%. And we are now going into the demographic transition. And so we said as a commission, we cannot bake ourselves new personnel. So we really need to work with the personnel which we have, and meaning that we become more efficient. So that we do on an ambulatory basis what we can do on an ambulatory basis to preserve workforce for the really more complex cases, and make at the same time the working conditions more attractive to get people back to people get to work. And of course, it's important I mean, we're a hospital commission, so we start from the hospital sector and see what we can change in the, or what we should change in the hospital sector. But it's clear that you can only reform the hospital sector if you see the interconnectedness with the other sector. And so a very important topic in the hospital reform is, what do we do with the small hospitals, which we do not really need as real hospitals, because we need to concentrate the more complex cases. But at the same time, we know that we treat inappropriately ambulatory care sensitive condition patients in big hospitals, and they could be better treated in centers which combine the best of the two worlds. So you treat them on an ambulatory basis, but at the same time you have beds in cases people need at least overnight or for a few days the bed. So it's important to think across sectors. And I think the trade-off, to come back to your question, between the resilience and efficiency is not easy, but both things have to be thought through. Thank you.
Thank you very much. Very good insights. And I think I want to go back to France with that, dwell a little bit on the hospital reform, because in the past I have actually looked at the French healthcare system, and I remember at the time, at least, very similar ideas were around, and I think they're still there, about consolidating a little bit hospitals, building networks, specializing. And I know it's exceedingly difficult to do this reform, a little bit from a also regional policy perspective, because the smaller hospitals are often important in more rural areas, can be very important employers, etc. So I would just like to know where you are in this process, and what you think, where you will be going forward, and does the pandemic perhaps help with this reform, or is it the same reform hurdle as before? Catherine? Did you hear me?
I cannot, yes, sorry, I don't really know, don't understand the reason why I was mute, but okay. So I was saying that it's work in progress. We are on this way. We've been trying to have a consolidation, stratification, and going through moderate expertise to highly expertise center, usually university hospital, dedicated to very transplantation, dedicated to the most severe cases. The point actually we have to deal with is where are the doctors, where are the nurses in our town, in our country, in our big countries or very small countries. And this is, I think, for the last year, this is the most, I think it's one of the most important problems we have to deal with. You know, during this winter, we have to face a crisis in hospital, because of we have a huge requirement of emergency room. But when we were considering who was coming to the emergency room, there was some influenza, there was some pediatric epidemics, but maybe a little more intense than it used to be, but not so intense. And when we were considering where are the people from the city, where are the doctors from the city, where are the first line, and we are very afraid that this first line based on doctors or nurses are just decreasing from year to year, and our projection said that it's gonna be better in 10 years. So if you want a very highly selected hospital, then you need to have very efficient care for outpatient. Because at the end, otherwise, at the end, the only place where there is light 24 hours a day and 7 days a week is the hospital. So this is, I would say that this is the problem we have to deal with nowadays in France.
And so having something like maison de santé, so basically that could be a solution.
So maison de santé means that people working together because they are young doctors, are young nurses, but young doctors do not want to work isolated anymore. They want to work together. So maison de santé is a way they can put together. You have a GP, you can have specialists, you can have cardiologists, you can have, but for outpatient. And so this this way of practicing medicine is in accordance with what is expected for the young generations. And I think one of our major points, and I think we share this through our countries, is how to deal with the expectation of our young generation of healthcare workers, where there are doctors or nurses. They don't want to work 24 hours a day. They want to have a better equilibre, I don't know how to say that, between personal life and work life. And so this kind of way to change the way they are practicing their medicine is a way to keep them on board and to be able to offer medicine maybe with a different way to do it, but still to offer the right level of medicine for the outpatients. Right.
Thank you. Yeah, maison de santé.
Sorry, maybe I would like really to emphasize this because the expectation of the new generation has to be really to be taken into account, because it won't work the way it works even 10 years ago.
Yes. And I remember the discussion, maybe we can go into this later, but the polyclinics, I think, are something like that in Germany.
Quite similar.
Yeah, and I think, so I was thinking it could treat two problems. One is that sometimes people go to emergency care just because nothing else is open. And I remember in France, this was discussed as an alternative because people could work different shifts, but also to the, respond to the demands and needs of the healthcare workforce. But I want to come to something very different on the question that's a bit technical from the audience, but we do want to take up the question. So it was put to you, Matthias Meeves from the Parliament, about the data sharing, etc., the problems with data protection. And the question was whether one hurdle was that Länder, perhaps that's international a problem, if it's indeed a problem, seem to interpret the European General Data Protection Regulation differently. So are these things issues? So really do you have to go into regulations and European rules in order to make sure, and how they're being implemented in order to be sure that data can be used much more efficiently in the future to guide not only through pandemics, but to improve healthcare overall?
So I tried to explain it not in a technical way. So first of all, yes, it is a problem in Germany. And yes, we want to tackle that. So please imagine you are BioNTech. You might have heard of this company. If this company wants to perform a study Germany-wide, so not only in the host state of Rheinland-Pfalz, but among various states in Germany. At the moment, it's very difficult to do that because BioNTech might have to treat with various institutions about data protection. And second, BioNTech might have to do with various laws around hospitals and about data usage in hospitals. So the landscape in Germany around data protection is very fragmented in the dimension of who is responsible for that, which institution. You might have to deal with various institutions and responsible institutions. And the second issue is that we have various hospital laws that might differ from each other. And that makes it very difficult and in a lot of cases impossible to perform nationwide clinical research or perform studies where you might use health data. So we need to tackle this, because otherwise we will lose a lot of potential in the field of science, in the field of research, and that's why we need to clarify, first of all, who is responsible for data protection regulation in Germany, and second, we need to overrule, in the end, 16 different hospital laws that basically say something about health data usage. And what are we going to do? We will bring to the German Bundestag a law around health data usage to clarify all that and make it easier to perform clinical studies in Germany, to use data in the health sector. The exact solution, how we will do it, is not clear yet. That's in intensive discussion, but we are working on that, and we will bring a law to the table shortly.
Gabriela, perhaps I would like to know from you, because Austria is often quite similar to Germany, but this whole issue of data protection versus using and sharing data, is that a big issue in Austria too? And if so, are you making progress with that?
We have the same problem. Yes, I can tell you we make no progress. I think this is a huge topic, and what we need is also real-time data. So we are far away from this topic be solved. Yeah? I fully agree.
Thank you very much. And Phil, I think I want to move to something else, one of your slides, and perhaps dig a little bit deeper with you, because you said, well, one thing to be resilient is really to have healthy populations, right? And of course, now here we have a lot of hospital representatives in hospitals, university hospitals, so they're doing research, but also they operate, they do complicated treatments, etc. And if I understand your point correctly, it's basically about preventing having all of those chronic diseases, cardiovascular diseases. So obesity was a big also risk factor in this pandemic. So yeah, how to do this? And does it mean we focus less on hospitals and more on prevention, or what is the recommendation that you worked out in the report?
So yeah, it's an important issue, and I mean the focus we took, as I said, is what happens when the system gets under crisis is you don't have the opportunity to do everything. You don't have the opportunity to both look after those people during the crisis and continue the care and operations that you are doing. So if you've set your system up so that you are required to continue to give the care in the hospitals, you've got a problem, because you've got both sets of people needing to be in the hospitals. And potentially, as Professor Russo was saying, it may not simply be an issue of having more hospital beds, because if you adapt your activity to the level of hospital beds, you've still got this problem. So the question is, can you help the system in these times of crisis? And the answer is, perhaps you can, if you can reduce the consequences of people not being in hospital. And the easiest way to reduce the consequences of not being in hospital is for them not to require it. Now, the question then becomes, do you end up with a lot less hospital activity? And I think that's a question that we need to look at very carefully. You should end up with some less hospital activity associated with care of conditions that can be treated equally well or perhaps even better in the community. But eventually people are going to age, and eventually they are going to require treatment. So I'm not convinced that you're going to end up with everyone having not to require hospital treatment. But the idea is that you lower the consequences of having to delay hospital treatment for a short period of time. Now, I think ideally, either when you're during a crisis or not during a crisis, people who are better treated not out of hospital and people who are better treated by having their conditions prevented rather than treated, you should take that approach. Thanks.
Thank you. Yeah, Hajo Krömer, perhaps basically to link into that, I think you're in the process of building up a big research center about prevention. And given healthcare staff shortages that are looming, not mainly because of the pandemic, but more because of demographics. So do you think this is, how important is this for the future of a resilient, sustainable healthcare system? And who needs to contribute here? Is it more general social policies, because we also know that poverty is closely linked to chronic disease? Is it general practitioners who need to push people to move more, to eat better? Or is there also contribution to be made from university hospitals, the research perhaps, or other things? How do you see this issue, and is prevention enough emphasized today in our health?
The answer to the latter question is really no. Generally speaking, at Charité, we are convinced that prevention is one of the major issues of the future. And a part of that can be related also to activities by the hospital, by hospitals or by academic medical centers. The major point in prevention, I think, is dealing with workforce shortages due to demographic change. This is something you can address by prevention. In part, prevention and digitalization are two major issues to be used, and prevention in that goes far beyond eating an apple per day or don't drink alcohol, things which nobody will adhere to, but are going to personalized high-tech prevention in predicting individual risk factors for an individual person. That's where we are going, and we do that in the field of cardiovascular, where we know most people die of. The resilience to the system in an acute crisis, in an abstract way, has something to do with prevention. But from our experience, the acute resilience in an acute crisis has a lot to do with the organization of the hospital, the way you can manage that. And I think we got some experience in Berlin because in an area of 3.5 million people, all severe COVID cases were concentrated at Charité. So we downgraded all our other activities to really treat these really sick people. And so in the acute crisis, it was the management of the hospital. Indirectly, of course, the overall health situation of a population is influenced by prevention factors. So it makes lots of sense in kind of preparing for a crisis, trying to increase the overall health status of your population. And to answer your starting question again, I think prevention is completely underestimated. There's this general saying that there's no glory in prevention. I'm convinced of the contrary. If you do it right, prevention can hold a lot of positive issues for overall health of the society. We just did not go into that. And it'll take a huge alliance starting at the academic medical centers and going down to individual healthcare workers in the community. If you look at some countries, naming the example of Israel, how they do that, how they really have a continuous care also in prevention, there's something I think we can learn of.
Professor Busse, you raised your hand, and I was actually going to ask you a question, but
Oh
please
yeah,
jump in.
then feel free. I just wanted to add maybe first that clearly prevention and care are closely related. We shall not forget that even if we have a totally successful prevention program and we would reduce the burden of disease, if the incentives for hospitals are still like they are in many countries, hospitals would then treat the less ill persons in order to make money. So it's not that there is this, because often people think it's a trade-off, that if we are all healthy, that the hospitals would be empty. No, the hospital to have less utilization in the hospital also requires there's a structural reform, reimbursement reform, and so on. So these things should be seen together.
And how would that work? So can hospitals, how would you change the incentives of hospitals to contribute to prevention, or let's say to really allow the alleviation of the healthcare system that you can have with successful prevention?
Well, part of it is a good hospital planning, which means that the number of beds, both normal beds, intensive care beds, should really reflect the burden of disease, taking in obviously some room for sudden crises and pandemics and so on. But if you have overcapacities, there is no matter how you pay hospitals, there will be some, they will feel, because they are physicians, they are nurses, that they don't want to sit around, they want to treat patients, and so there will be unnecessary patients. So hospital planning, capacity planning is key, but also the payment. And payment, as we know, there are two extremes. You could give the hospitals a budget, so they would get, 10 million per year ex ante, and then don't do anything, which is one extreme, which is not good. And the other extreme is you only pay for activity, whether it's fee for service or diagnosis related groups, which is also bad, because then they fill the beds to get as much money as possible for activity. So the challenge is to combine the two ways of payments. Budgets are good for the hospitals to be able to treat patients in case they need treatment, but also get some money to pay for staff in times when there is less necessity to do so. But clearly, you also need some activity-based payment. So the blending is the solution.
Thank you very much. And we have an interesting question from the audience, from Shira Menoni, and she's asking, yeah, but does prevention, would it not necessitate a completely different approach to research also? Wouldn't it have to be much more interdisciplinary and from a systemic perspective? And perhaps Catherine, I can ask you, so how do you discuss prevention in France, also with an aging society, but less than Germany? How would you integrate that? How do you envision integrating that more into the healthcare system? And how about that question? Do you have thoughts on that? Do we need more interdisciplinary research in order to do justice to the idea of prevention?
Well, I can say I'm not really the specialist of this, but maybe one point was to answer the question about the One Health approach. To my opinion, this is the good way we should go on, and because I am really convinced that we need interdisciplinary approach, and if we are considering what we are doing right now in France, I think that prevention is still the poor of the system, and I think we can and we have to do much better on this. What university hospital can do for help is first to be sure that every occasion we have to give our patients the right treatment. Usually we do acute care, and when we are considering, do they have all the advice all these patient needs. So we have usually you can find that, in fact, not really. So we are very basic. It's basic, but it's in the quality of care we give. The second point for a university hospital is research, for sure, and going through what are the agents, what we need to do, but also how can we personalize the approach for our patient, for the population. So this is research. And to end with the answer of the question once again, I think One Health is a good way to approach also research. And so it means working on all the important different impacts we can get on. But to come back to what we are right now in France, it's my opinion, but I'm pretty sure that prevention could be much on the top of the pile.
Thank you very much. Matthias, this interdisciplinarity, I think that it would be interesting to learn how that, whether, and if so, how it plays a role also in policy making in Parliament, because health is linked to the quality of the environment. It's linked to your wealth, to your income. It's linked to how much you move, how you eat, etc. So you could say it's linked to social policies, education policies, many other things. Is there time to think about health and prevention in this way when you're passing laws? And do you exchange with the sports committee? I don't know. We presented another OECD report last week about insufficient mobility. How is this approached in Parliament? Or do you you have your law on data, you have your law on hospitals, and then you have to fight to get it through?
Yeah, interesting question again. And yes, interdisciplinary work is very important. And I believe we need to take the time to think about it, how we make it work. And it's always difficult in politics, but in other areas in the healthcare system to really make time to really do it. But we need to do it. And myself, I do it. I travel to other countries. I talk to a lot of people in various areas to develop solutions together. And in the end, what is our specific job in politics to do? I believe the biggest job is to break down the silos which we still have in the German system. The silos are still existing not only in the area of data. I talked about that just a few minutes ago, but the silos exist in the various sectors in the healthcare system as well. So the ambulance sector is completely separated from the clinical sector in Germany in terms of remuneration of the financing, how things are being paid in Germany. And those silos, those sectors need to work together. And in the upcoming legislations, we need to invest a lot of brain, a lot of good ideas and concepts to break down these silos. And with that point, I come back to the hospital reform we do. In the end, it's not only a hospital reform, it is a reform that brings the ambulant and the clinical sector closer together. And if we do it right, it creates a more open health system where in the end, it's not the most important thing to stay in the silos, in the sectors, but to deliver the best solution to the patients. And that should be the goal of all our work. And our job in politics is to break down these silos. They are still very strong. And actually the egoisms that drive these silos are strong as well. And it will be a hard job. And I hope I see all of you supporting that when we break down these silos to foster interdisciplinary work in the health system. Does that answer your question?
Yes, thank you. And we, well, at least on my screen, we lost Gabriela. I was just going to ask her a question. I hope she will come back. But maybe I can put it to you, Professor Krömer. So again, a little bit the prevention idea. So is it imaginable that, for example, when you, and I don't think it's the case today, but perhaps you can correct me if I'm wrong. Let's say you treat a patient with important cardiovascular diseases in the hospital, that they sort of get a recipe for well, doing more sports or eating differently. Can that be the future, or do you direct them to some ambulatory care that would do this? How do you see this interaction between hospitals and more prevention or ambulatory care?
I think, I mean, Reinhard Busse made that very clear, that today's task of a hospital is not really in prevention. And I'm convinced that this has to change. And we have to integrate preventive measures into our activities also at the hospital. And this is improved or much easier than earlier with the sensor technology. If you have, I take a simple cardiovascular example. If you have an Apple Watch now, you can detect a certain rhythm disorder, atrial fibrillation, within a couple of minutes instead of months when you see the doctor the next time. And you can do that 24 hours per day. So you can look at these data in an automated manner at your hospital. You can accompany patients for 24 hours, and you can prevent strokes arising from this particular rhythm disorder based on this simple, not simple, but based on this kind of technology. So prevention in the future, I think, has something to do with a healthy life. You should reduce your calorie intake and don't drink too much and these type of things. But in due course, we can be much more specific based on individualized knowledge about the patient, which is related to genetic parameters, to environmental parameters, and to social parameters. We all integrate that, or we try to integrate that into a biosystem of an individual patient, and based on that, you can predict the value of prevention. And I'm convinced that we just have to go there. There was so far there was no real incentive to do that, but I want to put that very clear for Germany. We will lose within the next 10 years. We will lose, based on birth rates, about a third of our workforce. And it's simply impossible to replace it by immigration or do something like that. We can do part of that. But in general, we have to deal with the population we have currently. And if we want to keep our health system, which is actually pretty good in Germany, at the current level, we have to go in part in prevention. So it's from my point of view, it's pretty clear. Also politically, it's not a choice, but it's something we have to do. And I think also on the OECD level, for other countries which are in there, we should simply put a larger emphasis in the area of prevention.
Yeah, thanks. Thank you very much, Reinhard Busse. Maybe you can pick up on that a little bit on 2 points. I think I would like to prompt you. So one is this idea of using data, individualized data, to be able to do more prevention, given the really the looming staff shortage, or in reality it's already there, but it's only going to get worse long before it gets better. And then this point that Catherine made, that in France they're saying, well, you know, we have to create something like polyclinics allowing doctors to work together, perhaps half time, you know, and I think there's a lot of desire not to work full time, partly because the medical profession there are more women, but perhaps also other reasons. But that's a difficult circle to square, right? If you have fewer people, but they would like to work shorter hours. So how do you see that? What needs to be done to cope with this staff shortage that's there and that's going to get worse?
Well, I mean, the first thing is that we are clear how much human input, how many human resources we need to treat health-related problems, and how much we can rely on better data, new technologies, and so on. Realizing obviously that progress, innovations also mean that we have new areas of need. I mean, we as epidemiologists say need is the burden of disease where the health system can do something to help people. So there are very critically ill people. We cannot do anything. They are not having need. But with new innovations, there will be new areas of need. We also need to realize that even though the general population, when we do good prevention, might be healthier, and so it's an important criterion. So we need to really concentrate workforce only where we need workforce, and we cannot rely on technologies, robots, and so on. Where we need humans, we need to ensure that the working conditions are good. And unlike what many people think, it's not primarily remuneration. Obviously, people also want to make money, but they also want to have autonomy. They want to be able to be involved making decisions. And for nurses in many countries, including my own, this is a problem because the degree of autonomy is very low, and they don't feel motivated. And that relates very well to your second point when we talked about the maisons in France. In the hospital reform, we are proposing that the basic level hospitals fall in two levels or in two sub-levels. We have the one which is a rural hospital far away from bigger hospitals, which also still needs emergency care and normal medical wards, surgical wards for people in the countryside. But that the other small hospitals will be transformed to what we call integrated ambulatory inpatient centers. And we are proposing that the medical treatment for those medical conditions is done more or less on a day basis, and the beds are reserved for people who have nursing needs, older people who don't have relatives who can take care of them in the short term. I mean, this is not a nursing home thing. And that is, I think, one of the least discussed issues yet of our reform proposal, that these bed wards in these integrated care centers can be led by better trained nurses, advanced nurse practitioners. So we catch two flies with one. What do you say in English? You know what I mean. that we say, the medical people concentrate on day surgery, and for the nurses it's more attractive to work there because they get the autonomy over the nursing treatment.
Yeah, I think that was actually something that was practiced in Eastern Germany also before. But Phil, I know that this I've seen this discussed in a number of systems, Scandinavia, for example, with very dispersed population. So in some ways, that's already one could say, or could one say that's sort of a good practice from other OECD countries that you would say that can be a good solution?
And I'll go even further than Europe. I'm an Australian, and that's the model we run. That we have because the distances are immense. We run very many facilities that are essentially run by skilled nursing practitioners, and using telehealth as a force multiplier for things when things get more complicated, as people were saying, the use of data and extending people's reach and ability using technology is incredibly important. But as we've discussed, it's also a potential demographic problem, in that we're looking to increase the data use and data ability in a population that may not be able to fully uptake it. So there's a lot of work that needs to be done both on the population and the patient side, as well as the provider side for that. And a lot of work needs to be done to make sure that the data solutions and the technology solutions are fit for purpose, both for the patients and the providers. Thanks.
And Phil, what about pharmacists? Couldn't they take over some roles in prevention? Also telling, I don't know, older people not only to take their pills, but telling people, oh, you look a bit you know, maybe you should do more sports, or I don't know what it could be. Is that a model also being used in OECD countries or discussed?
Yes, it's both been used and discussed. And as we were discussing, there was a number of role changes that occurred during COVID, especially around disease management by people, for the professionals they were seeing. So in some cases, those were pharmacists, both on disease management and also on continuation of medications. Now, I think this is a really good idea. Like, the idea of extending practice scope is one of the ways to deal with some of the workforce issues. However, the word of caution that I would say is that a number of these things occurred during a time of stress, and we need to evaluate them outside of stress and see whether they are the best way of doing things. But in general, the idea of increasing scope of practice and reserving some scope of practice for the places where they can be most effective makes a lot of sense, be that nurses, be that pharmacists, and be that other health professionals as well.
Yeah, so thank you very much, Bill, and thank you very much also to the rest of the panel. So we are approaching the end of our scheduled time, and I think we've really run through a large array of things here: prevention, making systems more resilient, how to transform the hospital system, how to improve it's working together with the ambulatory care, and finally also what to do to make the health care profession more attractive. Certainly there's much more to say, but then the European University Hospital Alliance is going to continue these discussions tomorrow. And I hope that our discussion today was good food for thought for the workshop tomorrow, but also for the audience. And thank you very much for all your inputs, for your questions. Thank you, Matthias Mieves, also from Parliament.
It was a pleasure.
Katrin Pogam, and I think Gabriela Kornick, she joined again, but somewhere hidden. Reinhard Busse, thank you very much for your insights, and Phil, and you too. I learned a lot, and I hope you'll have good discussions tomorrow.